We're ready to
Very
go.
good. Okay, good. Good afternoon, everyone. Thanks so much for joining for today's briefing. As always, I'll share some updates about COVID-19 metrics that are being tracked for LA County and what we're looking at moving forward. My presentation is going to be followed by an update on monkeypox by Dr. Singhal, the Chief Medical Director for the LA County Department of Public Health. And I have Dr. Balter with me today as well in case there are some questions about other infectious diseases that may be circulating. Specifically, I'm going to cover our current COVID-19 metrics. I'm going to look quickly at the LA County early alert signals. I'm going to talk about preparing for a possible winter surge, and then also provide information on newly available updated boosters for children 5 and older. I'll take slide 1. As always, I start by looking at the updated trend lines for cases, hospital admissions, and deaths in the county. In this figure, the green trend line shows the 7-day average of the number of cases that are reported daily, and it's measured using the vertical axis on the left. During the past week, an average of just under 950 cases were reported per day. That's a 20% decrease from the 7-day average of 1,185 cases reported per day last week. The 7-day average for the number of daily hospital admissions are shown by the orange line. That's measured using the vertical axis on the right. The decline in this metric has slowed, as you can see clearly, since the beginning of October, and in recent days it's actually plateaued. This past week there was an average of 73 admissions per day. The blue line on this slide shows the 7-day average number of deaths reported daily, and it's measured by the axis on the right. This metric has also plateaued with an average of 10 to 11 deaths reported per day both this week and last week. This week we're tragically reporting 3 more pediatric COVID-associated deaths. These deaths actually occurred earlier in the year during the winter surge. Although they occurred months ago, we only recently received the final coroner's report, which confirmed these deaths as COVID-associated. One child who passed away was between the ages of 0 and 4. One child was between the ages of 5 and 11, and one young person was between the ages of 12 and 17. Sadly, this does bring the total number of pediatric deaths associated with COVID-19 in LA County to 17. October 10th, this past Monday, was World Mental Health Day, and we cannot deny the toll that COVID-19 has had on our well-being, especially when it comes to living with the loss of loved ones. I want to give my condolences to families who are experiencing pain and grief and extend my wishes for healing and peace. Next slide. Using the CDC's community levels framework, LA County remains in the low community level. This is the 7th week in a row. Our weekly case rate declined further this past week to 65 cases per 100,000. The values that we're seeing for the rate of new COVID-19 hospital admissions and the proportion of beds occupied by COVID patients both remain stable with little change. For counties in the low community level, the CDC notes that there are protective actions we should continue to take, including staying up to date on vaccine and booster doses, isolating if we're a suspected or confirmed case of COVID-19, and wearing masks around others when we've had an exposure. Those at high risk of getting very sick should talk with their healthcare provider about additional appropriate prevention actions. To help prevent severe illness and the need for hospitalization, it's also important that people who are at higher risk, and that includes everyone 50 and older, know that free outpatient treatments are available if they test positive. Options can be discussed with your healthcare provider or with a public health practitioner. Prescription medications taken by mouth to treat COVID symptoms include Paxlovid, which is widely available and can be accessed through the public health telemedicine service. To learn more, please visit ph.lacounty.gov/COVID medicines, or you can call us at the Public Health Call Center, 1-833-540-0473. This line's open 7 days a week between 8 a.m. and 8:30 p.m. Next slide. The early alert signals for LA County align with the encouraging trends I just highlighted. All signals except new school classroom outbreaks are of low concern. While classroom outbreaks remain concerning, there has been a decrease from the 17 outbreaks I reported last week to 11 outbreaks this week. Next slide. This week, I can finally introduce our new updated wastewater concentration metric, which compares the combined wastewater viral concentration value each week from all 4 wastewater treatment plants that monitor the virus in LA County. And it compares this to the peak value that we saw in July 2022 during the summer surge. The slide shows the trend line for our new combined wastewater viral concentration data from the end of May to the very beginning of October. The blue line represents the population-weighted average SARS-CoV-2 concentration across the 4 wastewater treatment plants in LA County that monitor the virus. This includes Lancaster, Tapia, Hyperion, and the Joint Water Pollution Control Plant. We use this weighted average so that the 2 wastewater systems that serve a greater number of people account for a greater part of the final average than the 2 smaller systems. As a reminder, Hyperion and the Joint Water Pollution Control Plant serve a combined estimated 7.5 million people in LA County, while Lancaster and Tapia plants serve a combined estimate of 235,000 residents. In the middle of the blue trend line, you can see that the weighted average peaked in the middle of July. So this becomes our main reference point for this early alert metric. The dashed yellow line represents a level that's 30% of the July peak, and this will be our threshold for medium concern. And the red line represents 60% of the July peak, and this will be the threshold for high concern. As you can see, we're well under the 30% mark, currently at 21% of the July peak. The dip that you see the week of September 18th is due to data only being available for the larger 2 plants. So that decline needs to be interpreted with a lot of caution. Once we had sufficient data for the smaller plants available for the week of September 25th, that average came right back up. This indicates that we're not seeing a substantial decline in wastewater concentrations, and likely what we are seeing is that viral transmission is no longer decreasing across the county. Next steps. While we're very optimistic that the current situation with lower rates of transmission and therefore lower risk will continue for the next few weeks, we also need to be realistic and be prepared for the very real possibility of changes later this fall and winter. In 2020 and 2021, there were significant winter surges, resulting in huge increases in cases, followed by greater numbers of hospitalizations and deaths. And we've also seen a pattern of increases in cases associated with the proliferation of new variants or subvariants or sublineages that crowd out the dominant circulating virus strain, as the newly mutated viruses all have the potential to be more contagious, cause different symptoms, and challenge our immunity. Throughout the pandemic, we've noted that often increases in cases in Europe have been followed weeks later by increases in cases in the United States. For example, back in early of November 2021, Italy saw a dramatic increase in cases, with the number of new cases nearly doubling and then continuing to spiral up. This was the same pattern we saw in LA County about 6 weeks later. By following these trends in other countries, we can start to prepare to minimize the impact. Next slide. In these next 3 slides, I'm going to share some of the data that we're looking at to help us understand the potential risk for later this fall. This slide is the one that shows our historical trends for LA County COVID-19 cases, hospitalizations, and deaths going back to June of 2020. Looking at this graph, it's really clear that the 2 winter surges we have had so far are the most prominent, with smaller surges that were seen the summer of 2021 with the arrival of the Delta variant, and most recently the summer surge this year associated with multiple subvariants of the Omicron variant. The higher number of cases in the most recent winter and summer surges likely reflects that the newer circulating variants and subvariants have become more transmissible in 2022, leading us to anticipate that as there are increased mutations, this pattern may repeat itself. Fortunately, although cases were higher in the most recent surges, hospitalizations and deaths were lower, and you can see that clearly. This is likely due to a number of factors, including a greater level of population immunity through increased vaccination and prior infections, reminding us that we do have an important tool that we can use to reduce the risk of severe illness and death: vaccinations and boosters. Next slide. As we try to anticipate changes that may happen later this fall, we're paying close attention to the weekly updates of circulating virus strains in LA County. The most recently available data, as you can see here, shows that Omicron BA.5 continues to be the dominant subvariant, accounting for almost 91% of the specimens that were sequenced for the week that ended September 24th. However, for the last couple of weeks, we've reported small changes in multiple sublineages of the virus.
Can you repeat that?
Yeah. However, for the last couple of weeks, we've reported small changes in multiple sublineages of the virus. BA.4.6, represented on this graph by the yellow bars, decreased slightly, but very slightly, to 4.2% in the most recent week. I think it was at about 5% the week before. More recent data from CDC estimated that across the country, BA.4.6 has increased and now accounts for about 13.6% of specimens. BA.2.75, that's the pale green bars at the bottom, these show that in the most recent weeks we had a slight increase there as well, and now accounts for 1.5% of specimens. Note that so far only 3 LA County specimens have been shown to be BA.2.75.2. That's that descendant of BA.2.75 that folks are watching carefully because of the mutations on the spike protein. With so few specimens, this sublineage is not shown separately here, and it's included with BA.2.75. But just to let you know, we are sequencing for it, and should it increase, it'll get its own color on here. BF.7, shown by the bright blue at the top of the bars, also increased slightly, but just now accounts for slightly over 2% of sequenced specimens in the most recent week. As a reminder, BF.7 is also referred to as BA.5.2.1.7 because it's a descendant of BA.5. Given the relatively low numbers of recently sequenced specimens with these sublineages in LA County, there is no need for immediate concern. Some experts do predict, however, that these sublineages have a greater evolutionary advantage than their predecessors, meaning that they're more contagious, they can crowd out other circulating COVID viruses, and they can break through protections such as prior infections and vaccinations. And with the more recent data from CDC indicating increases in these sublineages, we'll need to continue to diligently monitor the circulating strains in LA County. Next slide. As I noted earlier, following trends in other countries has been helpful preparing for possible changes. These charts show the reported cases and 7-day averages over the past 30 days for France, Italy, the United Kingdom, and Germany. Across the board, as you can see, there's an increase in reported cases. Despite the United Kingdom case trend line appearing fairly flat in this graphic, the country's 7-day average for cases increased from approximately 7,200 on September 29th to over 8,900 on October 6th, following the trend that you can see in the other countries. Throughout the pandemic, trends in cases in Europe have served as a predictor for trends in cases in the United States. This was true at the beginning of the pandemic in March of 2020, and also before each of our subsequent surges, and we should be prepared for it to possibly be true again. The positive news is that we now know more about the virus and how it spreads. We know what works to decrease transmission, and we have tools to reduce the chances and severity of illness. This means that we can both prepare for and reduce the impact of any possible surge this winter. Next slide. There are specific steps that we can take to protect ourselves, our families, and our communities that can minimize the impact of a surge if one occurs. The simplest and most effective action any of us can take right now is to get the new bivalent COVID booster if it's been at least 2 months since your last COVID vaccine. This is especially important for anyone 65 and older and anyone with underlying health conditions. For a person who's not yet vaccinated, this would be the ideal time to start your primary series, well before the winter holidays and a possible surge. COVID vaccines, including the new bivalent booster, are widely available. You can find a place to get vaccinated by visiting ph.lacounty.gov/how-to-get-vaccinated. That'll help you find a vaccine provider near you. Another effective tool for reducing risk is to use testing effectively. Get tested 3 to 5 days after you've been exposed to someone with COVID or after traveling. Get tested if you develop COVID symptoms. This is especially true when we have lots of other respiratory viruses that are circulating. Test yourself before attending an indoor gathering, especially if any older adults or people with underlying health conditions are going to be present. If you're planning an indoor gathering with those at higher risk, consider requesting that guests test themselves before attending. If you've not done so already, now's the time to find the best ways to get tested. You can go to ph.lacounty.gov/COVID-tests/how to find a testing location near you. You can just also contact your local pharmacy to see if they're performing testing. Many people here, millions and millions of us, can take advantage of the better access to over-the-counter antigen tests that you can self-administer in your home or other location of your choosing. This year, all insurance plans are required to provide 8 free home tests a month to every insured member, whether by providing them directly or by reimbursing you after you buy them from a pharmacy or another location. It's a good idea to stock up on tests now, well before the winter holiday begins, so you can easily test whenever you need to. Next slide. Given how important it is to be up to date on vaccines, this slide reviews vaccination coverage for those 12 and older. And obviously, we did this slide yesterday, earlier than the information now that we do have these new vaccines available for younger children as well. But this does present the data for those 12 and older. Over 80% of residents aged 12 and older in LA County have completed their primary vaccine series against COVID-19. That's indicated by the yellow bar on the left. This number is impressive and reflects the strength of our communities. Community-based organizations, healthcare providers, neighbors helping neighbors, and essential workers all work together to make this possible. The green bar in the middle shows that 59% of those ages 12 and older who are eligible for an additional booster dose received at least 1 booster dose of the original monovalent vaccine. In contrast, only 7% of residents have received their bivalent booster, as shown by the blue bar on the right. Given the waning protection of the initial vaccines and boosters and waning natural immunity from prior infection, increasing the number of individuals boosted with the bivalent booster offers us the most hope for avoiding the disruption and devastation associated with both prior winter surges. We recognize that after almost 2 years of getting various doses of the vaccine, there is confusion among many of us on what we need to do in order to be well protected. It is relatively simple. If it's been more than 2 months since you received your last booster or your primary vaccine series, you are eligible for the new bivalent booster, which is the only vaccine that offers increased protection against Omicron. Having a prior infection is not a guarantee that you will not be reinfected. For those who completed their initial series with Pfizer, Moderna, J&J, or Novavax, and you didn't receive your first booster dose yet, you are still immediately eligible if it's been 2 months since your last dose for the bivalent booster. You do not need to get one of the earlier booster doses to then be eligible 2 months later for the bivalent booster. As a matter of fact, the only booster dose that's currently authorized in the United States is the bivalent booster. And for those who are vaccinated and already received the new bivalent booster, we could use your help. I encourage you to share your vaccine experience with others. Speak up when you hear misinformation. offer to help a neighbor schedule and get to their vaccine appointment, and make sure people around you know about the bivalent booster and that it's available. Getting more of us boosted is a goal we can all reach together. Next slide. With reports daily about increasing cases of flu, I do want to make sure that everyone knows that the seasonal flu vaccine is now widely available in LA County. This is a vaccine that individuals need to get every year. So if you got it last year, you need to get it again this year. You can find it at many pharmacies, your healthcare provider's office, public health centers, public health vaccination sites, and almost all of our mobile vaccine clinics. If you are homebound, you can also request an in-home vaccination visit. Studies conducted throughout the COVID-19 pandemic indicate that it's safe to receive both a COVID-19 vaccine and a flu vaccine at the same visit. The CDC and the Advisory Committee on Immunization Practices recommend this practice. Oftentimes, you hear about people trying to time their vaccines, waiting until the flu cases have risen, or until we are in the middle of a COVID surge. Getting your COVID bivalent booster and your flu vaccine now, before there's another winter surge, is your very best protection. It also provides greater protection for others in the community, including older adults and those with underlying health conditions. If you're interested in hosting a free mobile vaccine team at your work or community site to administer the flu vaccine, COVID vaccines, and the bivalent COVID booster, or all three of these, you can visit vaccinatelacounty.com, click on Host a Mobile Vaccine Clinic, and there you'll find a number of providers, including our own at Public Health, that you can send your requests to. Next slide. Yesterday, October 12th, the CDC director recommended the updated bivalent booster for children ages 5 and older. This is after the FDA provided emergency use authorization for the Pfizer bivalent booster for children ages 5 to 11 and for the Moderna bivalent booster for children ages 6 to 17. Over 300,000 children in LA County are now eligible for the bivalent boosters. For these age groups, Moderna is available now, and the Pfizer vaccines are expected by either late this week or next week. So it's a good idea to call your pharmacy or provider to confirm if the vaccines are in stock. The brand of booster administered does not have to match your original primary series. Out of the nearly 900,000 children in LA County that are ages 5 to 11, there are over 500,000 children that have not yet received their primary series. A child can receive their primary series now and then receive the bivalent booster 2 months after their last dose. This will provide a significant amount of protection against Omicron during the upcoming winter holidays. Next slide. For those families with children 6 and older who are 2 months out from the last dose of their primary series or a booster, there are sites offering the Moderna bivalent boosters for children aged 6 to 17 as soon as today. For those with children 5 to 11 who prefer to wait and receive the Pfizer pediatric bivalent boosters, there will be hundreds of sites across the county offering this booster sometime next week once shipments of the special pediatric bivalent vials arrive. Across the county, there are 625 sites right now that are planned to administer the bivalent booster for children ages 5 and older starting as soon as Wednesday, October 19th. These sites include providers, pharmacies, public health sites, and mobile health sites. To find sites, again, where these vaccines will be available, you can go to ph.lacounty.gov/how-to-get-vaccinated. You can select the type of vaccine you're looking for in your zip code, and hopefully you'll find a site right near you. In closing, what we know about COVID-19 now is very different than what was known at the beginning of the pandemic in March of 2020. We now know more about how it spreads, how it mutates, and how we can protect ourselves and the community. I encourage everyone to use the available tools to reduce the impact of this disease. As you prepare for the fall and winter, please know that the actions you take help protect the most vulnerable in our community, as well as your family and yourself. Next week, I want to just give a heads up to the media. We may be presenting at the Board of Supervisors meeting. If this is the case, as we discussed last week, We'll be foregoing the weekly Thursday press briefing. Please know all press is invited to the board meetings, and we'll keep you posted once we confirm the schedule. And now I'm pleased to introduce Dr. Singhal, the Chief Medical Director for the LA County Department of Public Health, who will give an update on monkeypox. And after that, of course, we're happy to answer your questions.
Thank you, Dr. Ferrer. There we go. All right, good afternoon. Thank you for being here. So today I'll be presenting our monkeypox update. I'm going to be covering a situational update, our latest case trend data for LA County, an update on our vaccination efforts, and some minor revisions in our vaccine eligibility. I'll go ahead and take the first slide, please. I'd like to begin with our usual situational update. At this time, over 72,000 monkeypox cases have been reported globally. Of these, over 27,000 were reported in the United States, and 5,136 of them are here in California. We can also report that as of today, there have been 2,109 cases in LA County, as well as 119 cases in Long Beach and 27 cases in Pasadena. The profile of cases continues to align with what we've seen so far, including among vulnerable groups and in high-risk settings. For instance, the proportion of cases among people experiencing homelessness, or PEH, remains stable at 6%, and there are no new jail cases to report. In addition, our hospitalization rate remains low at 5% of our total cases, or 95 individuals hospitalized since the start of the outbreak. We continue to see a higher case rate among the Black African American population, but as reported last week, the rates for all race ethnic groups are declining. Next slide, please. Next, I'll review our latest monkeypox case trend data, which is shown here on our epidemiological or EPI curve for number of monkeypox cases by episode date. The blue bars indicate daily case numbers, and the pink trend line indicates the 7-day average cases. As you can see, we've continued to see a steady decline in cases. As of October 1st, our 7-day average cases dropped to 5, which is the lowest that we have seen since the first week in July. As I shared last week, this is consistent with a slowing in the growth rate of the outbreak in the United States, which the CDC notes is likely due to increased immunity due to both vaccination and infection, along with changes in behavior. In addition, monkeypox is a self-limiting virus that does not transmit easily, as it requires close skin-to-skin or intimate contact. It's difficult to predict the trajectory of monkeypox cases moving forward, but in the short term, CDC expects that daily cases in the United States will most likely continue to decline or plateau over the next several weeks. However, they note that cases are not declining in all U.S. jurisdictions and that domestic transmission is unlikely to be eliminated in the United States in the near future. Furthermore, while the United States, Canada, and European countries are experiencing declines, the incidence in some countries is increasing or has plateaued in recent weeks. Thus, even if community transmission in LA County remains low, we will likely continue to see cases that are imported from other states or countries. We plan to continue to closely monitor trends in LA County and demographics of new cases with the hope that the current declines will be sustained. Next slide, please. I'd like to share a brief update on our monkeypox vaccination efforts. Last week, we hit a milestone with over 100,000 JYNNEOS vaccine doses administered. This includes over 72,000 first doses of JYNNEOS and over 30,000 second doses administered. Public Health extends its thanks to all of the healthcare providers and community partners who helped us to reach this important milestone. We continue to track the number of individuals who have been vaccinated with one dose and are due for their second. Currently, a little over half of those due for a second dose have not yet received it. Next slide, please. Next, I'd like to present some trends in vaccination over time. This chart shows the total doses of the JYNNEOS vaccine that were administered between the week ending May 29th through the week ending October 9th, broken down by first and second doses. The blue bars represent the bars represent the number of vaccines administered each week. The blue portion of the bar represents first doses, and the red portion represents second doses. As you can see, the total number of weekly doses administered peaked in the last week of August with over 13,000 doses administered, and then have declined each week to slightly under 3,300 doses administered in the week ending October 9th. The number of first doses administered peaked the week of August 14th with 9,495 doses. Since then, there's been a fairly steady decline of first doses administered, with just over 1,400 administered last week. You can also see that beginning the week ending September 18th, over half of the total weekly doses administered are second doses. Although our weekly doses administered has decreased substantially over the last few weeks, we are still seeing steady vaccination by our community providers as they continue to identify and vaccinate their eligible residents. We also continue to work with community organizations to identify locations where vaccinations can be made easily accessible to eligible residents. With ample supplies of vaccine and vaccination sites located throughout the county, we're strongly encouraging all residents who are eligible for vaccination to start and finish their 2-dose series. Next slide, please. We'll now look at who is currently eligible for the monkeypox vaccine. Of note, we have made some minor revisions to a couple of our criteria to align with new vaccine eligibility guidance from the California Department of Public Health. The monkeypox vaccine is available to residents who self-attest to being in any of the following groups: any man or transgender person who has sex with men or transgender persons, persons of any gender or sexual orientation who engage in commercial and/or transactional sex, and persons who have sex in association with a large public event, persons living with HIV, especially persons with uncontrolled or advanced HIV disease, persons who had skin-to-skin or intimate contact with someone with suspected or confirmed monkeypox, including those who have not yet been confirmed by public health, sexual partners of people in any of the above groups, and people who anticipate being in any of the above groups. Any persons who met prior eligibility criteria remain eligible for the vaccination. We know that certain communities are being disproportionately impacted by monkeypox while also having lower vaccination rates. Public health, with community providers and community-based organizations, are employing strategies such as holding informative monkeypox educational events, developing culturally appropriate messaging, and identifying trusted messengers and channels for delivery of the information to reach these communities. Next slide, please. In closing, public health sites and community clinics are available throughout the county to provide monkeypox vaccinations. For more information and to learn your options for getting vaccinated, including locating vaccination sites, please visit ph.lacounty.gov/monkeypox. You can also call the DPH call center at 833-540-0473. Thank you.
Go ahead and open it up for questions. We'll get you.
Dr. Ferrer. Yeah. Okay, so I was a little confused. I think I know the answer, but I just want to.
Okay.
You talked about, given the low number of sublineages, we were talking about the winter months, given the low, which sublineages are you worried about breaking through?
Yeah.
And we were talking like about the BA5, sublineages, and there were so many.
Yeah.
Which ones are you worried about breaking
Well,
through?
so, what we're hearing, obviously, from researchers is that they're worried about 3 in particular right now. But you're right to note that there's a lot of mutations within Omicron. I think if you remember way back, like what we saw were changes in the variants. Like we had Epsilon, we had Delta, we had Omicron. Now what we have and have had for the last year are just a lot of subvariants and then sublineages. So what we're worried about now are sublineages of BA.4, which, remember, circulated a lot at the beginning of the summer surge. And that in particular we're tracking, as is everyone across this country, BA.4.6. It doesn't mean that at some point very soon somebody's going to tell us that there is a BA.4.6 dot something else, because the example on that is we're also tracking a sublineage of BA.5 that because there are so many numbers after it, they now call it BF.7. But those are BA.4 and BA.5 sublineages that have been shown, particularly in lab studies, to have significant mutations in ways that would indicate they're going to evade some of our protections. This is particularly a vaccine protection or natural immunity protection, and that they appear to be highly infectious. So that's similar to what we've been living with for the last, many months now, these highly infectious variants. The tools that we have are protecting us somewhat from the severe illness, lots of hospitalizations and lots of deaths. But there's been tons of transmission during the surges, and every time we have tons of transmission, we have more cases in the hospital and more people dying. So we're going to worry about the case numbers. The other one that they're tracking is, remember BA.2, that was the winter of 2021, 2022. Now we have BA.2.75 and a variation on that, which we've seen very little of. But those are the ones that right now in the United States we're spending a fair amount of time tracking. CDC has more updated data than we do, and they're seeing, the one that they're seeing increase the most in the United States right now is BA.4.6. But that doesn't mean that we're not going to see a proliferation of any of the other ones, or that there's not going to be a new subvariant or sublineage that we need to work with. I show that table because the one thing that's interesting is they're only increasing a very small amount each week, if they're increasing at all. And we can all remember, like especially when we flipped from BA.1 and BA.2 to BA.4 and BA.5, how quickly those started dominating. So far, we don't see that.
But the vaccines do provide some protection.
Yes, the vaccines provide a lot of protection against hospitalizations and deaths. And because the bivalent booster is really targeting BA.4 and BA.5, it will be a good match for those sublineages, better than what we've had. This will be the first time we're going to enter into a winter with a vaccine that actually is well matched to what's circulating right now. So that's our push.
But of course, the big problem is only 7%.
Yes, that's a very big problem.
Yeah.
I think there's fatigue about getting vaccinated over and over. I think there's confusion. I talked to a lot of people that just said, but I got boosted. And they feel like, I got my booster. I got it months ago, but I got boosted. Why would I need another booster? So it's really on us at Public Health and our community partners to make it much easier for folks to understand why we all need to get an additional booster this fall. The analogy is more akin to flu, where, you get vaccinated every single year because the protection you got from the prior year wanes, and there's likely to be a new strain or multiple strains that are circulating and dominating, requiring a better match with the vaccines. We're very lucky that the booster that's available is an exact match to what's circulating. That doesn't always happen, but we have to make sure people understand why you need to get this booster this fall. So that next time we're talking about this, it's not 7%. We need to really rapidly increase those numbers, certainly before we get into the holiday season.
I had another question. What are the primary subvariants that are circulating in Europe, in France, Germany?
Yeah, that's a good question. I think it's BA.4.6 in Europe, with maybe some. I know BA.2.75 is not really crowding out yet, but I think maybe Denmark is seeing BA. And the UK. So that's why everyone's tracking. Like the things we're tracking are because they've showed up somewhere, seem to be increasing, and seem to be capable of spreading pretty rapidly.
But BA.4.6, the one that you're tracking,
We're tracking all of them.
right, the one that you're more concerned about, is that, to clarify, is that producing less severe disease like BA.5, or we don't know that?
We don't know that yet. I mean, we don't have enough of it here. All of them seem to be very easily transmitted. For us, what we have going for us that some other countries don't is we've got a booster that's actually targeted for BA.4 and BA.5. Not all countries have that booster or administering a booster that's specifically targeted. So we're going to have to wait and see how well our booster is performing with what's circulating. But, we anticipate based on studies that we have a good match and it ought to be highly effective. Initial data that CDC released, I think, a couple of weeks ago also showed evidence that these boosters are going to be very effective.
If people get them.
If people get them.
So, that leads to today, you spent some time saying that, share your story.
Yes.
Loud and proud if you've been vaccinated.
Yes.
Last week, we learned that you have not received
Yes.
bivalent booster. You said that you were waiting to be cleared.
Yes.
You said that your personal story with the vaccines is complicated.
Yes.
That begs the question, have you received your primary
Yes.
COVID-19 vaccine?
I've received both my 2 initial doses and my 2 booster doses, and I will be getting the bivalent booster either tomorrow or Saturday.
How do we stand on the bivalent vaccine supplies for the county?
We have enough for everyone who's eligible. We're going to have no shortage.
No shortage?
There will be no shortage. We just need people to come in and get vaccinated.
Do you anticipate a surge with people not choosing to take the vaccine after Thanksgiving?
Well, we're likely to see a surge because the conditions that we are in during the fall and the winter really have more people gathering indoors. As I reported a couple of weeks ago, the virus kind of thrives with lower humidity, indoors, less air circulation, drier, our mucous membranes are drier. What I know would be a real benefit to us is if more people are getting boosted, we'll see lower hospitalization numbers and lower death numbers. Like that is a given. If we can do that for sure, we could avoid what happened the last 2 winters, which is a real strain on our healthcare system. What the hope is that if enough of us can get that bivalent booster, we're going to also reduce transmission risks. Now, even though lots of us fully vaxxed have gotten infected, if you look at our data, your chances of getting infected are still 2 times greater if you're unvaccinated than if you're vaccinated. So no matter what, getting up to date on your vaccines and getting vaccinated gives you some protection from transmission. It's just we all remember when we started and it was like 20 times less likely to get infected at the very beginning if you got vaccinated than if you were unvaccinated. And over time, those numbers have dropped, in part reflecting this waning immunity issue. So we need to boost our systems. That's how this vaccine works best against a coronavirus, which is a different virus than some of the other viruses we may get vaccinated against.
Will you be documenting your experience tomorrow, or will you get the shot?
Well,
At some point, you said
yeah.
to share it. And
Yeah, it's a great idea.
Inspired.
Brett, I'll work with Brett to figure that out.
Be there.
Yes. I'm happy to.
Thanks, Bob. It's all on you.
Yes, I'm happy to. And I'm also, I want to just really encourage people there. I'm not the only person who has special health conditions that mean sort of working closely with a healthcare provider to determine the timing. But if you're somebody like me who has health conditions that require that, I do urge you to talk to your provider about going ahead and trying to figure out when would be the optimal time for you to get that vaccine so that over the next few weeks you're able to go ahead and do that. Some of us have to really be very careful on the scheduling, but I don't want people to get discouraged. I've done this. I hear it from some of my friends. I've done this. I've had to work with my doctor. I'm really sick of this. I'm just going to be super cautious, particularly for people with underlying health conditions or people who have special health circumstances. Work with your provider to make sure you're able to go ahead and schedule that vaccine.
Is it really fair, though, to compare the flu vaccine to the COVID-19 vaccine in that in the third year of the pandemic, that means if you got your annual flu vaccine, you have 3 shots. There are people who have, what?
5 shots.
6 shots perhaps? at
5
this point?
shots, most.
5 shots?
5
within
shots?
the-
I think so, yes.
So
People,
5 shots within under 3 years. That's a lot of shots. So moving
it is a lot of
forward,
shots.
I mean, do you think it's realistic to get the public knowing how much fatigue there is out there? And is that really necessary, given that we're down to 950 cases at this point?
Yeah. I think anytime you have vaccine preventable illness, it's really important to stress that one easy way to reduce your risk is to go ahead and get vaccines. Like, we all are going to have some risk because nothing's perfect. But if you want to reduce your risk, and in this case, as with all vaccines, you reduce risk to others as well, you want to go ahead and get vaccinated. The mortality rate from COVID is still too high, and everybody is saying that. Like, everybody looking at the data acknowledges too many people still dying. And a lot of people who die are people who are either older and have, serious health conditions, or they're just super, older enough that their immune systems are not working as well, or they're people with underlying health conditions. But as I told everyone before, 25% of the people who die are under the age of 65. And every day we hear about people who are dying who actually have no underlying health conditions either. So nobody should think they're going to be risk-free. And I think it's like too high a risk to take to decide I'm going to just take my chances and get infected rather than get vaccinated, because as you pointed out, I've already been vaccinated a bunch. We still have long COVID. We still have for children MIS-C. We still have the unknown around, what this does with multiple reinfections to your long-term health conditions. So we're blessed. I mean, from where I'm sitting, we're blessed that we have vaccines, and now we have a booster that's really targeting what's circulating right now. And people should appreciate the fact that we live in a well-resourced country where vaccines are available for free to everyone, and they offer us a high degree of protection against the very worst outcomes of what still is a deadly virus. It's also, from my perspective, one of the ways we really get a handle on trying to get to a place where the pandemic really is not causing the level of disruption and devastation that it still causes.
Well, the White House COVID-19 coordinator said that COVID-19 is no longer the disruptor that it was. So we know that at this point.
And a lot of that is due to the fact that people are vaccinated. I mean, I report 81% of LA County residents 12 and older are vaccinated. That makes a big difference. And that's one of the reasons why the hospitalization numbers are down. But we need people to continue to update their protection if they've already been vaccinated, and if they're not yet vaccinated, to really think about talking to people about their concerns so that their questions can get answered and they can come in and make use of this effective layer of protection.
I just want to read some quick questions from Ron Lynn at
Oh, yeah.
Times. We'll go back to the room in a second. 4 questions. On the super duper flu shot for seniors this year, how does it work, and do seniors need to specifically request it? The second question is, are you hearing whether long COVID patients are having trouble getting treatment because demand is high and resources are low? Third is, why are COVID hospitalizations no longer decreasing? And then number 4, about Ebola, is how prepared is LA County for Ebola, given there's no vaccine for this strain?
Yeah, great questions, Ron. I'm going to take a stab at sort of what's going on with long COVID patients, and then the fact that we don't see a decrease in hospitalizations at the moment. And then I'm going to ask Dr. Balter to come up and talk about flu shots for people who are older, and your last question on preparedness around Ebola, because obviously this county is prepared. But let me answer the question on sort of long COVID. I still think people are having trouble securing care for a variety of reasons. One is there's no clear-cut definition still of long COVID. Many people are just trying to get on with their lives after they've been infected and they've had that initial recovery, and they aren't really sure when they should go out and seek care. And then, as you noted, there are only a handful of places that actually advertise themselves, as providing specialty care for people with long COVID, which means those places are, of course, seeing many more patients than they're able to easily manage in what I would say is an appropriate period of time. So we are aware that there are many people who are struggling to get support and to even figure out what their options might be around care. I also want to note I'm very grateful for our team here that works with our providers so that our providers have a deeper understanding of what they should be looking for around long COVID and how to make sure that patients that are experiencing symptoms that are often associated with long COVID, or even symptoms that are unusual for them that are happening after they've recovered from an initial infection, are getting appropriate care and appropriate referrals. But it is a complicated area. I wish that we knew more. I mean, long COVID is one of those areas where we still need a lot more research to better understand and come up with a good definition, but also to better target treatments and support to people who are struggling. I will say it's alarming when you look at some of the recent research that says as many as 20% to 40% of people who have been infected with COVID are experiencing some form of long COVID weeks and weeks out from their initial infection. In terms of the no decrease in hospitalizations, we'll have to look at this trend over a longer period of time for starters, because sometimes we plateau because now the numbers are so much lower that small changes are going to make a pretty big difference in our trend line. So we'll have to watch this more carefully. I would assume that with higher rates of reinfections, we're going to have to track very carefully, again, whether that's resulting for some people, those who are most vulnerable, in higher rates now of needing hospitalizations. But I don't think that's what we're seeing yet in this plateauing. I think this might just be reflecting sort of the lower numbers of people that are hospitalized and a little bit of noise in the data. If we continue to see a plateau while our case numbers decline, I would also venture to say that the case numbers declining, as we've noted before and why we talk about wastewater concentrations, are not a true measure of transmission any longer. So the fact that hospitalizations aren't going down might really reflect that cases aren't really going down either, that the case reports that we get continue to show lower numbers, but in fact, what we're really experiencing is a plateauing as well on the numbers of people getting infected. And again, that's why we try to triangulate the wastewater data, because that helps us understand what might be going on at a larger scale around transmission when many of the test results are no longer reported to us. And I'm going to turn it over to Dr. Bolter for the other two questions.
Did you want me to repeat them?
It was flu and Ebola.
Correct.
So on flu, yes, absolutely. Seniors get a vaccine that's either a higher dose or has something called an adjuvant, which makes it stronger. And the reason for this is, as we age, our immune systems unfortunately decline. It's the reason that we see more disease in elderly. It's also the reason that, as you may recall, children got a different dose of COVID vaccine. It's not that they're smaller, it's that their immune systems are stronger and can react to it better. So the flip side is, at the other end, you need a stronger vaccine. So although I would hope that when seniors present to get their vaccine, they will be offered the senior dose, it's always a good idea to ask. It's possible that if it's not available, you could just go to another drugstore or another location and get the senior dose. On Ebola, absolutely. We are working closely with our state and federal partners to prepare. We're working closely with CDC. They're doing, as you know, screening. Everybody who's coming from Uganda are being routed to certain airports which are not located in LA, so we will have a heads up if anybody is coming from the region. We also have a regional treatment center here. Our lab is available to test, and we're in contact, again, with CDC on a regular basis. We also work closely with EMS and our other state partners. I don't know if there are any other specific questions on Ebola.
Government.
Can you say your first and last name and your title for us?
Oh, my name is Dr. Sharon Balter, and I'm the director of the Acute Communicable Disease Control Program.
And can you spell your last name for us, please?
Balter, B as in boy, A-L-T-E-R.
Any follow-ups in the room?
Emily, do you? I have one question. Can you react to the Pfizer executive who was before the European Union? Did you see that? Who was saying that, no?
I didn't see it. What was he saying?
She was saying that they did not test the vaccine on its ability to prevent transmission prior to the release of the public because it was such a quick release.
For the booster, for the bivalent booster, or for just initially?
Initially.
I think Dr. Balter could
You know,
comment.
yeah, just to comment on transmission, we actually didn't really expect that it would prevent transmission because of the way coronaviruses spread and mutate. We were surprised initially at how well it did that. We did try to communicate that the testing, and they said that it prevented people from becoming severely ill or hospitalized. And it did that. And I think to what Dr. Ferrer said earlier and to what you said earlier, you know, we're grateful to have the vaccines. They've had this huge impact. We are not where we were in 2020. And a number of my friends who've had COVID after having been vaccinated have said, wow, that was really rough. Imagine if I hadn't been vaccinated. So, you know, I know that many researchers are trying to figure out if they can come up with a vaccine that will prevent transmission, but they haven't done that yet.
I think the other thing that's worth noting is sort of what happens when what you're trying to do is match the vaccine to the strains that are circulating. So similar to influenza, where there are different strains that circulate, it's super hard to spend a lot of time testing, particularly on transmission, because by the time you're done with your clinical trials, there's likely to be different strains that might be circulating. So I think the science behind the science and the technology behind how they develop the booster dose remains exactly the same as the science that went into the original formulations. All that they've done is they've changed the strains, I mean the little pieces of RNA that are in those strains that get used to activate our own immune systems. So it really doesn't require the same level of clinical testing that the original vaccines did. What we needed to see was the safety data, which was shown to us and was actually very good. I think you're raising this point on, will this help us prevent transmission? We can only note that it's going to be more targeted in its ability to help our immune systems respond to what's circulating now. And we can point to our data that shows that while it's not its primary goal, the vaccines still do help people who are vaccinated prevent some transmission. They still have some protection against transmission, and it's likely with a targeted vaccine as what we have with the bivalent boosters, we might also get that other advantage, similar to what we saw at the beginning, where we had, you know, some very decent protection against transmission. But we'll have to look at the real world data, real-time data, that we're collecting to assess that.
All right, thank you, everybody.
Thank you.